First speaker is Dr. DrSiow from Malaysia. She works at the Indah Eye Center. She completed her oculoplastic training many years ago, I think more than a decade ago, at the Singapore National Eye Center.
Thank you very much. Thank you, Vanessa. Hi, everyone. Thank you for choosing to spend your afternoon attending our instruction course. So I will kick off this session with just a basic talk on lower eyelid blepharoplasty patient evaluation and lower eyelid anatomy. I have no conflict of interest to declare. So I will touch on applied lower eyelid anatomy and surface topography, the pathophysiology of aging on lower eyelid, and also clinical evaluation. Lower eyelid blepharoplasty is a common cosmetic surgical procedure. It is technically demanding, requires meticulous planning and careful execution. The aim of the surgery is to achieve a smooth lower eyelid contour with seamless transition to the cheek. So understanding of surgical anatomy, effects of aging, and proper patient evaluation is key to a successful surgery. Just briefly on surface topography. The lower eyelid margin rests at the inferior corneal limbus, with the lowest point just temporal to the pupil center. This picture shows a canthal tilt. The canthal tilt is the location of the lateral canthus in relation to the medial canthus. And a positive canthal tilt gives a sign of youthfulness. So you can see in this aging eye, there is a negative canthal tilt. By restoring the positive canthal tilt, there is an instantaneous, improved, and more youthful appearance. These periorbital grooves are important in surgical as well as non-surgical lower eyelid rejuvenation. I will touch a bit more in a later slide regarding the anatomical correlations. So this is the critical zone, which is an area of 0.5 centimeter radius, inferolateral and 30 degrees temporal to the lateral canthus. This area contains the terminal twigs of the zygomatic branches of the facial nerve, which supplies the pretarsal and the preseptal orbicularis. Injury to this area during vigorous dissection in lower lid transcutaneous blepharoplasty may result in iatrogenic paralytic ectropion, so caution should be exercised. So we're all very familiar with this picture from our training days. The lower eyelid consists of three separate layers, which is the anterior, middle, and the posterior layer. In transcutaneous lower eyelid blepharoplasty, the approach can either be through dissection through a skin flap approach or a skin muscle flap approach. While transconjunctival lower eyelid blepharoplasty is more direct, just by breaching the conjunctival, we will encounter the fat compartment directly. There are three distinct fat compartments in the lower eyelid, which is the medial, the middle, and the lateral fat pad. The medial fat pad is separated from the middle fat pad by the inferior oblique muscle, while the central and the lateral fat pad is divided by the arcuate expansion of the Lordwood's ligament. So the important landmark is the inferior oblique muscle, which we will need to try to avoid during vigorous dissection. So nowadays, oculoplastic aesthetic surgery has evolved into oculofacial aesthetic surgery. As such, our knowledge should extend to structures beyond the inferior orbital rim. So inferior to the orbital fat pad is the suborbicularis oculi fat pad, and lower down is the malar fat pad. So in aging, the weakening of the orbital septum will give rise to pseudoherniation of the orbital fat pad as well as the sub-fat pad. So this is the midface. There are two important connective tissue structures here, which is the orbicularis retaining ligament and the zygomatico-cutaneous ligament. The orbicularis retaining ligament expands from the inferior part of the orbicularis to the inferior orbital rim, and medially it is also known as the Kirchhoff ligament, where it is sandwiched between the maxillary origin of the preseptal orbicularis and the orbital orbicularis. So as promised, these are the anatomical correlations of the groove. The Kirchhoff deformity is located between the preseptal and the orbital orbicularis, while the nasojugular groove marks the inferior border of the orbicularis oculi muscle. Okay, so a little bit on the effects of aging of the lower eyelid. As you can see in the youthful face, there is a prominent lateral and anterior prominent lateral and anterior cheek projection so that the globe actually rests behind this projection. So in the youthful profile, it is described as having a positive vector. While in the aging eye, the globe is seen more anterior, while there is a soft tissue deflation of the cheek. So the lateral cheek projection and the anterior cheek projection is much less prominent. So this gives rise to an increased vertical eyelid height because there is a descent of the malar fat pad. So finally, we come to patient evaluation. These are basically relevant evaluation that we will take in most of the patients with eyelids for eyelid surgery. So we need to take note of chronic medical conditions such as hypertension, diabetes, any thyroid, cardiac events, or bleeding or clotting disorders. And medications which are relevant would be medications which can promote bleeding, or any medications that can influence any dry eye symptoms. And also patients should also be evaluated for dry eye symptoms and dry eye disease. So when looking at the patient, we evaluate the lower eyelid and the cheek for the hills and the valleys. So when we look at the lower eyelid fat prolapse, you can see in this picture that the subtle changes are more prominent on upgaze and is masked in the downgaze. We will also look at the cheek, at the malar anatomy, noting whether there is any malar prominence and the presence or absence of hollows. And the lower eyelid distraction test will also let us know whether there is any medial or lateral canthal laxity. The skin also will be scrutinized to see whether there is any skin excess and also the quality of the skin. So a careful evaluation will aid the surgeon in doing a good surgical planning. Excess of skin will aid us to decide whether to go transconjunctivally with or without a skin pinch skin excision or for a transcutaneous approach directly. Poor skin quality can be augmented with some resurfacing procedures. And if there is a significant negative canthal tilt or canthal laxity, horizontal leg tightening procedures or canthal tightening can be considered. As for the presence of any fat prolapse, any loss of cheek prominence or malar grooves, this will guide us in managing the orbital fat, whether to aggressively or conservatively excise the fat, to reposition or to redrape, whether the mid-face lift will need to be considered, and whether any augmentation will need to be done further on with fillers. So in conclusion, the aim of lower eyelid rejuvenation is to restore the youthful periorbital profile by addressing age-related changes of soft tissue excess, laxity, as well as volume descent and mole distribution. A clear understanding of lower eyelid anatomy is key to a successful surgery and avoiding potential complications. And in the modern day, lower eyelid blepharoplasty has expanded to include mid-face for a more seamless rejuvenation. Thank you very much.